This is Southern Discomfort. The federal response to the deadly coronavirus pandemic under President Trump has been a public health disaster, with more than 230,000 Americans dead and no clear end in sight. In sharp contrast, President-elect Joe Biden has pledged to mount a serious response against the pandemic. Biden recently announced a panel of healthcare experts to begin to counter a surge of COVID-19 hospitalizations throughout the country. On the matter of health reform, however, the president-elect has offered measures that would merely bolster and even expand the same private health insurance system that has prompted physicians and other frontline healthcare workers to feel like they are fighting COVID-19 with one hand tied behind their backs. Biden ran on returning the country to normalcy, but there was nothing normal about the American healthcare system before the pandemic. The truth is, our dysfunctional medical system remains an outlier among the rest of the so-called developed world. The United States produces some of the worst health outcomes in the industrialized world and devours an ever-increasing share of our economy, with healthcare spending accounting for an astounding 17.9% of the GDP, with nothing to show for it. As many as 250,000 Americans die each year from medical errors. That's more than the amount of people who have died from COVID-19. Is that the kind of return to normalcy that Americans want, need, or deserve? The answer, of course, is no. Poll after poll has shown that Americans want a universal, single-payer healthcare system that is focused on meeting human needs and not the needs of investors. Medical care under a single-payer system, usually referred to as Medicare for all, would be universal, meaning everyone in the United States, including undocumented immigrants, would have equal access to treatment. It would be free at the point of care, since there would be no premiums and no cost sharing, and unlike our current Medicare program for seniors, vision, dental, and long-term care services would be covered too. Medicare for all isn't a silver bullet, but it will go a long way in lifting people out of poverty. It won't raise wages directly, but it will embolden workers to join together to demand better pay and improved working conditions, as they will no longer fear losing their health coverage. Single-payer is a reform, but it has radical implications. The right to healthcare is relevant to every person and has the potential to empower other human rights struggles. There are few parts of the country that would benefit from Medicare for all more than the South. Health outcomes in southern states continue to lag behind the rest of the country. Infant mortality rates in the region remain the highest in the nation, particularly within communities of color, while southern states account for more than half of new HIV diagnoses. Rural hospitals across the South are closing at an alarming rate compared to the rest of the nation, leaving patients to worry about receiving even life-saving medical treatment. To make matters worse, the majority of states in the South refuse to expand Medicaid under the Affordable Care Act, leaving thousands of people without access to health care. The coronavirus pandemic has provided us with an opportunity to make sweeping changes to our social welfare system, but they are destined to fail without the support of people living in the South. Private health insurers, pharmaceutical companies, and banks, which have ensnared millions of Americans indebted by medical expenses, stand to lose too much if America moves to a single-payer system. They have and will continue to fight tooth and nail to keep the money flowing for as long as they can. Joining me now to talk about the ways that the South is particularly unprepared to withstand the coronavirus pandemic, and how Southerners can and must be at the forefront of the Medicare for All movement, is Rita Valenti. For the last 40 years, Valenti has been on the front lines of the fight for health equity, first as a nurse, and later as a fierce advocate for single-payer as a board member of Healthcare Now. She spoke to me from her home in Atlanta, Georgia. Rita, you've been a nurse for 40 years. Have you practiced the entire time in the South?
Yeah, all of it. Let's see, I was living in Birmingham and went to nursing school in Birmingham and then finished up here in Atlanta and worked for a few years at DeKalb and then worked at Grady, both in trauma at the mothership, the big house, as we call it. And then later, I guess about the last 18 years of my nursing career, I worked at the Grady Infectious Disease Clinic.
Wow, so you have some good insights into the coronavirus pandemic.
That has been my major focus for the last 8 months, both because I'm an RN that is fairly knowledgeable about infectious disease, or has at least some knowledge about infectious disease, and also because of the different grassroots organizations I work in. Many had a lot of questions, particularly when the pandemic first broke out. And initially, I was trying to focus with other people on the science of this. What does this mean? How is it transmitted? All of those questions. And of course, NNU, National Nurses United, had initiated letter writing to Congress and to HHS back in January, knowing that this pandemic would be coming here and that we were ill prepared. And then, of course, as we all know, this situation has gone from bad to worse.
Health outcomes among southern states lagged behind the rest of the country even before the coronavirus pandemic. Can you talk about how Southerners, especially people of color and low-wage workers, have been disproportionately impacted by COVID-19?
I guess the major thing about the pandemic that is important for the South is the way basically the federal government punted it to the states. The states, in turn, punted it to the counties. Counties punted it to cities. Cities punted it to individual hospitals, and now even individual schools, in a struggle to get the kind of PPE or necessary equipment that they needed. All of that was essentially at the mercy of private corporations, because there was very little, there's almost no public health infrastructure to speak of in Georgia. So it's been a very traumatic experience, I think, for Georgians, and I would say probably for people throughout the South. We already came into this pandemic on equal footing, particularly Black, Latinx, and indigenous peoples, as well as immigrant people, which is a huge piece of this puzzle around the coronavirus that is not being addressed. I mean, the South came into this pandemic on equal footing. We are the stroke belt. We are the congestive heart failure belt. We are the diabetes belt. Georgia is like 49th in healthcare metrics, and that follows throughout southern states. Usually Mississippi, as always, is at the bottom. But with the failure to expand Medicaid, on top of the inequality that's inherent inside of Medicaid anyway, the crisis around the coronavirus has really impacted particularly the rural South. In the last 6 months, 2 more rural hospitals are closing. One of them was an essential access hospital. We had one of the largest outbreaks of the coronavirus in Dougherty County, which is really at the heart of the Black Belt in Georgia, around the city of Albany. And, it's very interesting because the narrative that's often promoted, particularly by Governor Kemp, but the narrative is usually to blame the people themselves, right? Kemp was the governor that closed the state of Georgia down on April 4th and opened it first on April 24th with no viral control and no mask mandate. Opened nail salons, bowling alleys, etc. during this time. And of course, the virus continued to spread, and the blame was placed on the people, particularly in the rural area, not recognizing that one of the other dynamics that exists in the rural South is that we have a disproportionate amount of prisons, detention centers, and nursing homes, because a lot of the rural population is also elderly. And, with no resources, no solid resources really made available either for testing, treatment, or personal protective equipment, we had viral explosions in the rural areas, and of course in the city too, in Atlanta. This is still going on, Jonathan, and one of the problems that we're facing now is that the numbers are actually being hidden. They're not being reported. It's sort of this philosophy: if we don't talk about it, it just goes away. And of course, again, that stems from our governor, and is also reflected by number 45 as well. Schools open early in most southern states. Some of our schools opened in August, and a lot of that, or at least around the metro area, most of that was done by virtual learning. But in areas outside of the metro area, it was in person. And, immediately there were viral cases. There are still cases going on inside of the schools, but they are now not being reported. And the school superintendents are using the excuse that it's a HIPAA violation. And I know you know what HIPAA is. It's a Patient Privacy Protection Act, which of course has absolutely nothing to do with providing the necessary data about how coronavirus is spreading. Just to layer one more piece on this is hospitals, or at least some of the hospitals, are not reporting the amount of coronavirus cases that they're experiencing in the hospitals. So here we are in the middle of a global pandemic with no mask mandate, not a lot of social distancing, and the numbers are being hidden. So we're fighting this pandemic literally blindfolded and with two hands tied behind our back. So it's a very dangerous and very worrisome situation about how we get this virus under control when we essentially have a states' rights doctrine developing the narrative and the policy around coronavirus control.
Are you at all surprised that this has been the outcome? What were your hopes when the pandemic started, and how has that matched up with the reality on the ground?
I mean, that's a really good question. I think that one of the things that's been shocking is the throwing of science under the bus. I think that's extremely dangerous. Well, clearly, as we've seen, costing lives in Georgia, about 7,500 lives, and then, of course, around the country, over 230,000 deaths. Georgia has over 336,000 cases. But the throwing of science under the bus was the thing that was most discouraging. And seeing public health officials essentially putting political considerations ahead of the truth of science is a situation that I think needs to be talked about a lot more. It's also exposed what many people have spoken about, the dual pandemic of racism and the coronavirus, and of course, institutional racism, institutional white supremacy is inherent in the way our healthcare system has been developed. And it's been also, unfortunately, part of the legacy of when we did have a public healthcare system too, sort of a two-edged sword of public health. On the one hand, playing a role to ensure that workers were healthy enough to go to a job and reproduce a working class. But on the other hand, a history that is rooted in eugenics, also tied to how people in the South have come to have a distrust of many healthcare institutions because of that history.
What's been fascinating to me has been to witness the southernization of the federal government. A lot of the things that we're seeing now on the federal level, not that they haven't existed before, but now it really seems to be taking the lead of the South on many different fronts. We've always known that the South leads the way, whether it's promoting racism, or quashing workers' rights, or denying people health care, but it's become very clearly defined during this pandemic.
That is absolutely true. And as the saying goes, Wall Street controls the South and the South controls the nation. And so goes the South, so goes the nation. But I think you've raised something that's really important and true, is that the South also is the lead in transforming society. The various markers that have historically been dominant in southern states have now, spread throughout the country, whether it's right to work laws or mass incarceration or various other aspects of Southern history that is now playing out, particularly in the Midwest, I think. And I think that has a lot to do with the role that healthcare plays in society, the way that this healthcare system, the American healthcare system, is played in society. As I said before, playing a role to ensure a healthy working class. Well, when the factories put robots in where people used to be in Detroit, and where people used to labor on the land, and now it's done by mass tractors and artificial intelligence technologies, we see a decreasing need for human labor. And the healthcare system begins to transform itself into a system for itself, to perpetuate profit or revenues, rather than a system to support the health and well-being of the people.
What was healthcare like in the U.S. when you first began practicing as a nurse versus how it is today?
Well, there are several things that have happened incrementally, increasingly over my 40 years as an RN. One thing is, the United States set up a system of commercial health insurance, right? I mean, commercial health insurers, I guess it started around in the 30s. Initially, Blue Cross Blue Shield, for example, health insurance was not for profit. And as a result of that, got a lot of tax benefits and whatnot. I remember working, and, your insurance was essentially covered by the job. And over a period of time, the worker had to pay more and more out of our own pockets into that health insurance. It was in the 1990s, there was a massive move on the part of particularly Blue Cross Blue Shield to move from a not-for-profit to a for-profit. We actually sued here in Georgia. Our little band, Georgians for a Common Sense Health Plan at that time, sued the state to try to get the revenues of this transition from Blue Cross Blue Shield from a not-for-profit to a for-profit, because they've been given so many tax benefits over the years as a result of being a not-for-profit. There was a whole period of time in the 90s where these foundations were created called conversion foundations as a result of these suits. But I guess that the major difference, or the two major differences, is one, an increase of privatization. More and more of the large county hospitals, or even the small town hospitals that were public or community run or county run, have closed. Of course, we see that throughout the rural areas most profoundly. So the increase in privatization of healthcare institutions. Two is the consolidation of the private insurance industry into about 4 or 5, dominant health insurers with billions or perhaps even $1 trillion worth of revenue. Three is, more and more of that has come out of the pocket of the worker, particularly these so-called high deductible healthcare savings accounts. That was another big piece where the premiums would be reduced for the employer, for the worker, but the rub was in the amount of the deductible, which I don't know exactly what that is now, but almost all large employers adopted that. And so you have deductibles of upwards from $1,500 to $6,000 for coverage for a family of 4, these kinds of things. And then, of course, the other side of that is the amount of jobs that no longer offer health insurance. I came south, as I said, about 40 years ago from Detroit, and having a job was usually a guarantee of having health insurance. That's no longer the case. The amount of employers that actually offer health insurance, and the bulk of so much of that falls on the back of the worker, has increased exponentially. So that's a really really good question. And there's a lot of nodal points in there about changes that have been made that are basically an extraction of wealth from the backs of working and poor people into the hands of insurance companies, and increasingly also into the hands of technology companies. And that's another change that we've seen really exponentially since the introduction of electronic medical records back, well, in the South it was a little later, but I guess, the early 2000s when electronic medical records were introduced. And now, of course, tech companies are becoming a dominant force inside of the healthcare industry, period.
Naomi Klein had an article in The Intercept recently describing what she calls a Screen New Deal. It's an initiative promoted by big tech companies that are pushing to transform physical distancing precautions implemented in the wake of the pandemic in order to save lives into a highly profitable, no-touch future. Why is that particularly disconcerting to you when it comes to healing and caring for patients?
For the last few years, various corporations, whether it's Apple or Microsoft or IBM or what have you, right, have been courting healthcare professionals and hospitals and even the insurance companies later, courting them, trying to increase their presence through using mobile apps and or things like telehealth, right? Well, a lot of people were very, sort of reluctant, particularly as it went on the path of telehealth. And once the pandemic hit, all of that evaporated within weeks, right? And now, theoretically, I can go to a bar in Georgia and get a drink, but if I have to see my doctor, unless it's really urgent, I should have a telehealth appointment, right? And one of the other concerns about telehealth, aside from the lack of human contact, which is absolutely essential to the health and well-being of people dealing with illness, is also, I think, a real strong move to substitute institutions of telehealth for on-the-ground healthcare practitioners, particularly in underserved areas, again, like the rural South. And of course, this poses a whole nother set of issues, especially when many rural communities may not have internet access, but they can, say, this is the direction we can take. Now, that's not to say that telehealth doesn't have a role, because it could have a terrific role. Say, for example, you're in a rural area and you do actually have primary care physicians or nurse practitioners, PAs in the area, which is the way it should be. And then somebody has perhaps a very developed, difficult medical diagnosis, and they need to consult with a neurosurgeon, who are not ubiquitous anyway, right? So, if you had a primary care provider sitting down with a patient, having a joint conference with a neurosurgeon, in another area, that could be a very positive use for telehealth. But as a substitute for human contact, as a substitute for touch, smell, hear, listen, all of the things you need to do when you're dealing with people with illness, that's not the answer. So that's another thing that has come about. And lastly, on this thought, and it also relates back to the history of eugenics too, is the institution of artificial intelligence in healthcare. And I'm not 100% sure about how all that's working, but I do know that AI is dependent upon algorithms and also dependent upon big data. And there is no place where you can get more big data from than in healthcare. And that's one of the moves that the technology companies are also trying to figure out, is how to capture all of this big data and then apply algorithms to whatever commercial product they want to sell as a result of that. And those algorithms inherently, either consciously or unconsciously, reflect the dominant, ideology that this ruling elite has promoted inside of our society, and that's white supremacy. So, this horrific eugenic history can be carried out. The content can remain very much similar to the historic content, but the form is changing. Although not in all instances, as I mentioned before, the Irwin County Detention Center instance. So.
Just to bring everyone up to speed, a nurse at the Irwin County Detention Center blew the whistle on a doctor accused of forcibly sterilizing immigrant women without their knowledge or consent. The horrific stories coming out of the detention center recalled the South's long and shameful history of forcibly sterilizing poor women, particularly women of color, and the disabled. Several years ago, I wrote about North Carolina's shameful eugenics program, which actually ramped up the forced sterilizations of poor black and white citizens even after the human rights crimes of the Holocaust had been exposed to the world. By 1974, 7,600 men, women, and children from every county in North Carolina had been forcibly sterilized.
The massive sterilizations that took place, well, certainly North Carolina has that history, and I'm also thinking about Mississippi too. If you look at that history, if you sort of pull out that history, you have the history of slavery, where enslaved women were used as breeders. I mean, it's even hard to articulate that. It's hard to even say that, right? And then as sharecropping developed, and then later, at the end, after slavery, and then you had sharecropping, and then as the international harvester came in, and sharecropping was no longer a viable way to sustain oneself, you had another form of eugenics, which was the mass sterilizations. Like you said, in North Carolina, people that were no longer considered needed for work. And, that was people like Fannie Lou Hamer, who suffered the Mississippi appendectomy, and then thousands and thousands of others. There were indigenous tribes. There was an indigenous tribe that was sterilized to the point of extinction. So it's a frightening history. It's alive today at the Irwin County Detention Center in South Georgia. We know that there were women that were sterilized. These were immigrant women, mostly from Central America, seeking asylum as their crops had failed from climate change, and as experiencing legal and extra-legal violence, in different countries in Central America. And they came for asylum and ended up in detention centers, Stewart Detention Center, Irwin Detention Center, and there was no precautions around the coronavirus. And there were, many instances of positive coronavirus spread in those areas and in the communities surrounding those areas, because, the guards and the employees didn't have PPE either. But recently, it has also come to light that some of those women were sterilized without their knowledge and without their consent.
So what prompted you to finally join the movement for single-payer healthcare?
A lot of stuff developed out of the civil rights movement, right? Certainly the passage of Medicare and Medicaid, and then as well, on the heels of that, OSHA laws and various other structural reforms. In, I think it was 1977, Ron Dellums in California introduced a plan for a national health service, similar to a British model, and later a little bit like a Cuban model. And of course, that was red baited and didn't go anywhere. In 1988, I think it was, I was a nurse. I was also doing a lot of work at the Georgia State Capitol, and eventually ran for a Georgia seat in the Georgia House of Representatives and won. But right around that period of time, the article came out, I think it was the New England Journal of Medicine by Himmelstein and Woolhandler, about, single payer. right? If we can't look to Cuba, maybe we can look to Canada. National health insurance, everybody in, nobody out. And we had a little group already working on healthcare issues in the disability community and a number of other issues that were coming up. And we grabbed onto this. And then in 1992, our organization, through my position in the Georgia House, introduced single-payer legislation for the state of Georgia at that time.
Can you talk more about your single-payer bill and how it was received by the public?
It was great, actually. We knew that it wasn't going to pass. I mean, we were very clear about that. It was actually a resolution, but what the resolutions did was frame the kind of public insurance that we should have and how it should be used and how it could be directed and what global budgeting was and what would be covered, which was everything. There would be no copays, no deductibles, all of that. So knowing that it wouldn't pass on the one hand, but on the other hand, we got tremendous amount of press on that. The Atlanta Journal-Constitution actually wrote editorials supporting it. This is in 1992. So the public response, we did a poll, and I think the numbers are pretty close to, well, I think the numbers are even better today, but back then, 65% of Georgians were in support of it. And that was in 92. I'm sure the numbers today for improved and expanded Medicare for all are even higher than that.
What role have Southerners like Fannie Lou Hamer and organizations like the Medical Committee for Civil Rights played in the fight to pass Medicare and Medicaid and other flashpoints in the longer struggle to establish healthcare as a human right?
You know, when Medicaid and Medicare were passed in 65, the Mississippi Freedom Democratic Party, of which Fannie Lou Hamer was a member, had a platform or was developing a platform. And they made it very clear that Medicaid would not be a solution for the South, but Medicare for all. And indeed, the many of the authors of that legislation had always intended it to be extended to the entire population was the answer, because with Medicaid, you have additional restrictions and state control over how that actually works. And so, you know, historically, Southerners, well, in particular, the revolutionary leaders of SNCC and the Civil Rights Movement and the Mississippi Freedom Democratic Party and all of that, you know, were pretty clear that Medicaid was not going to be a solution for the healthcare issues that people in the South played. So that was a critical role. And as you mentioned, during Freedom Summer, initially there was an organization called the Medical Committee for Civil Rights, which was in New York. I can't remember what year it had actually started, 63, 64, something like that, where doctors were boycotting and were picketing the AMA because they excluded Black physicians. This is not ancient history, right? They excluded Black physicians. And a call came up from SNCC, from the South, from doctors, from Black doctors like Robert Smith and from Bob Moses and people like that, came up to the North saying, we need healthcare practitioners down here to help us as we're being beaten in our demonstrations and marches in order to achieve the vote and to end segregation and legal segregation in the South. And so there was a response, and that response came from, MCCR morphed into MCHR, the Medical Committee for Human Rights, and doctors and nurses came down to Mississippi during Freedom Summer in 64. And that was a very, very important piece of our history and a very, very important lesson, because here you had, predominantly white privileged professionals coming down to the rural South that was in the midst of a life and death struggle for civil rights. And how were those class and racial dynamics going to play out? there were obviously problems. There was obviously a huge amount of tension, but it also became clear that the leadership had to come from the community, and the providers that came down became very aware very quickly that it wasn't just their presence during these marches, which functioned as a calming force, a calming presence, as well as being able to address any brutality from a medical perspective. But also became clear that many people had never seen a doctor ever in their lives, and so issues of essential hypertension, which still is very prevalent within the Black community throughout the country, which many of us feel, is a direct result of white supremacy and chronic stress that leads to chronic inflammation that can lead to hypertension and many other diseases. And so in that process, with a relationship with a wonderful doc named Jack Geiger and Robert Smith and many others, created the Mississippi Mound Bayou Clinic. And in fact, I think that was one of the first, actually federal, eventually became partly federally funded clinic. At the time, it was a collaboration between the federal government as far as resources go and Tufts University. And then, of course, the community had much of the lead in that clinic. And they did things, Jonathan, like write prescriptions for food, because people had been kicked off their land when they were trying to achieve the vote and were starving, didn't have any way to feed themselves. So they wrote prescriptions for food. They created like tributaries of providers going out into the community to meet with and to treat people who lived in more isolated rural areas. This was done in 1965, and we don't have any kind of public healthcare system that's really doing that today. What does that say?
We have an opportunity right now, with almost 250,000 Americans dying from COVID-19, to pass legislation that would enshrine healthcare as a public good. Yet, even during a global pandemic, Republicans conspired to put our health into the hands of the free market, while Democrats proposed tinkering with incremental reforms like expanding on the Affordable Care Act, which we know has only further enriched the private health insurance industry at the expense of transformative reforms like Medicare for All. We saw Democrats squander their last big opportunity for sweeping social change during the Obama administration when they passed the ACA and decided to expand not Medicare, but Medicaid. Can you talk about how Southerners often pay the price for these insufficient measures and how they continue to resist the status quo?
All of the major structural reforms, I think, that this country has seen, certainly in the 20th century, and we haven't experienced any structural reforms in the 21st century, have emanated from the South. As the South goes, so goes the nation. But that also applies to the strategic leadership, I think, that Southern workers have and continue to play. And there are many revered institutions here that have continued to, well, you know that. You're in North Carolina. But, whether it's Highlander Center or Project South or at Penn Center, various strong, deeply rooted institutions that continue to organize and to lead a struggle, for justice and equality. And Medicare for All is a part of that. When Medicaid expansion, with the ACA became an issue, there were several things that struck me about that. One was that with the growth of Medicaid over the years, there were like 74 million people on Medicaid, which speaks volumes about poverty, because in the South, in order to be on Medicaid, you have to be pretty impoverished, right? And so when it became a question of expanding Medicaid, I thought, geez, we should be farther along than that. I am certainly not opposed to Medicaid expansion. If that could happen immediately, let's do it. But also immediately, we need a Medicare for All, because Medicaid is not equal. It, in many ways, reinforces health disparities through low reimbursement. And it's also, become privatized in that it's all Medicaid plans, where private entities basically control the healthcare access of the people. And in doing that, can keep more money for the entity that's in that kind of control. We're also looking at some of that problem with Medicare now. I'm obviously over 65. We have seen that progressively Medicare has become more privatized with these Medicare Advantage plans, right? Which are just sort of HMOs on steroids. And they're private for-profit plans that Medicare contracts with whatever insurance company is out there, whether it's Cigna or Aetna or the Blues or United Healthcare, et cetera. So we have to talk about Medicare for All is an improved and expanded Medicare for All, because one of the big, many of the reasons why we're talking about Medicare for All is that it at least creates a level playing field in order to be able to begin to address the horrific racial inequalities, healthcare disparities that exist. If we've got a big pot of publicly funded national health insurance program, we can direct some of that to the most underserved areas, right? And so that's why Medicare for All is also a health equity program. And it's a step. It is not by any stretch of the imagination the end-all be-all to healthcare disparity, but it is certainly an easy step to take in that direction. And I also want to say and make it very, very clear that the private health insurance industry really is a parasite on the illness of people, right? And so, with a Medicare for All, not a public option plan, which would ultimately fall under its own weight, it eliminates the role of the commercial health insurance industry in healthcare. And, you don't really need an additional parasite when you're already sick, possibly from a parasite like hookworm in Lowndes County, Alabama today, which was eradicated in 1906 because it made the workers in the textile area in North Carolina lethargic. So the Rockefeller Foundation came in and eliminated hookworm. And now we see it coming back again in areas of the rural South. So history lives with us, Jonathan. History lives with us.
I have been organizing around Medicare for All for several years now with an organization called Healthcare for All North Carolina, a chapter of Physicians for a National Health Program. Even though there's been a huge shift in the state in terms of the number of people organizing to win Medicare for All, the vast majority of nonprofits and Democratic Party-leaning organizations continue to focus their energy on expanding Medicaid under the ACA, even though the Republican-controlled legislature has remained firmly set against it for the past 10 years. I am in favor, of course, of expanding Medicaid, and I know a lot of Medicare for All advocates are as well. Do you have any suggestions for how we can talk about the need for Medicaid expansion, but at the same time underscore how Medicare for All is really the reform that we need, not more poverty programs?
Organizing and movement building is about building relationships, right? I mean, ultimately, so saying, yeah, okay, we do need to expand Medicaid, but we also need to pressure our congressmen to organize and mobilize for Medicare for All. I mean, and you're right. I mean, the mainstream Democratic Party, is essentially sticking with what existed for the last 20 years. And, if the pandemic showed us anything, it's that doesn't work. And as you also know, Medicaid was the compromise with the Dixiecrats when Medicare was passed, right? So because of the lower reimbursements of Medicaid, we had rural hospital closures over the years. Even when people, when some folks were able to have Medicaid. And we know that Medicaid reimbursement, as I said, is lower. It's difficult to say, yeah, okay, let's expand Medicaid, but people have to hold on to a vision of what's not only possible, but now is really necessary, right? I mean, Medicaid is not sufficient to cover. Well, one of the other things about Medicaid is you have to jump through hoops to figure out if you're eligible or ineligible. And if your income changes, you're out. And if your income goes up, you're out. women, for example, who give birth are only covered by Medicaid in Georgia for, I think, up to 3 months after giving birth. Now, the child may be covered, but the woman's not. So there's this big push in the Georgia state legislature to expand Medicaid coverage for the mom, I think, for another 6 months. This is ridiculous. This is absurd. What if mom gets sick at month 7, or month 8? Let's be realistic, right, about what the weaknesses of the program are and how the way that Medicaid is structured now is actually funneling a lot of public funds into private hands through these Medicaid arrangements. It's not a solution. But whereas Medicare for All also, with traditional Medicare for All, allows you some amount of choice. Now, the question of choice of like choosing your provider, which you usually can't do with Medicaid because they're all either HMOs and or a lot of providers won't accept them because the reimbursement is low, and there's bias, obviously a lot of racial bias among health professionals too. It is only a partial. It is not a solution to the extent of the healthcare crisis that we're actually experiencing. I mean, as long as healthcare is tied to employment, the situation is just going to continue to get worse, right? I mean, before the ACA, we had about 50 million people uninsured, and that's why the ACA was passed. So that number came down to about 27 to 30 million uninsured people. Then you had the pandemic, right? And you have the pandemic, and millions of people have been thrown out of work, and millions more will not get a job back because while we've been, while this pandemic has been raging, these corporations have been saying, maybe we don't need all these workers, because they've had to accelerate the institution of technologies that were already becoming a part of that process, right? So there'll be millions more. I don't know what the number of uninsured today in this country are. I would say it's probably close to at least 40 million people. And many, that's a big working class of people. That's people that, may have had decent incomes, as well as people that may have had little or no incomes. If we're going to divide up the healthcare according to how much you make and or what color of your skin is, we will never have the healthcare that we need. And we see that even more clearly in a pandemic that is airborne. Nobody is immune, right? I mean, even, I won't use the adjectives that are coming to mind, even this guy in the White House got coronavirus, right? And that's actually a little bit about what we understood in the very early days of public health with tuberculosis and various things like that, right? It is a community issue. Healthcare is an issue of well-being for all of our people, and this ideology of go it yourself, it's up to you, is not, it's a John Wayne ideology of hyper individualism, which is in contradiction to the way we actually live and the way we work and the way that we can't work.
You've been very clear about the important role that workers play in forcing transformative social change. Can you talk a little bit more about how workers are organizing to bring issues like Medicare for All forward into the public debate?
I have to say I'm very excited about the work in particular that both the Southern Movement Assembly, but especially the Southern Workers Assembly has been doing with the campaign Safe Jobs Saves Lives. Initially, when businesses started to reopen, the demand coming from workers, particularly city workers in your state, was, look, if we're going to go back and we're public workers, we're in the public, whether it's sanitation services or municipal services or county services, whatever, we're going to need the proper PPE, personal protective equipment. Of course, nurses, doctors, clinic assistants, radiology technicians, housekeepers, janitors, the whole 9 yards inside of the healthcare system need PPE. We've had thousands of healthcare workers die because they didn't have PPE. And, NNU has been taking a real leadership role in terms of talking about that. And it's not safe for the patients too. And then the Safe Jobs Saves Lives campaign kind of sums up both the relationship between the fight for Medicare for all and the fight for job safety. And it's also related, if I may say, to the issue of defund the police, right? Because defunding the police means funding the resources that we actually need, or at least that's a piece of what it means. And so right now, Jonathan, with the schools opening, we are on the cusp of yet another crisis. I just got off the phone with a friend of mine, let me put it like that, who has families that are teachers, and their schools have outbreaks of coronavirus, and their teachers do, and the schools are not reporting it. And the schools are still open. So, teachers now, too, are part of this front line. And the last thing I want to say about the pandemic and workers is this notion of essential workers, which I think actually it was Homeland Security that made the designations of essential workers. And of course, that was forcing primarily people of color, often immigrant people, into the meatpacking and poultry plants that you have to work, whether you have PPE or not. That's totally egregious and has also led to hot spots or outbreaks of coronavirus, again, in a lot of rural areas, certainly in Iowa and certainly in Georgia as well. The irony in all this is that, essential work is essential for the worker. We don't have the kind of public healthcare system where if you have to stay home and quarantine, or if you're sick, you are fully compensated, your needs are met, food is delivered, you have somebody coming to your house to check on you, you have, rent and mortgage forgiveness. You have all of these things that you need in order to survive so that you can regain your health, right? And that's the kind of massive public health infrastructure that we could actually have. And a poor country like Cuba actually does have a lot of that in place. And we've seen other countries that are capitalist, even do that job a whole lot better. China, Singapore, Hong Kong, Vietnam has done an incredible job of controlling this virus, because if things had to be shuttered, if things had to be closed, if people had to quarantine, they were not facing extreme poverty, starvation, eviction, and job loss, which is what the American worker faces.
What role do you think the South can and must play going forward in the Medicare for All movement?
I think the role we're playing. I think we need to come together as much as possible throughout the South and raise our voices for improved and expanded Medicare for all. I think that improved and expanded Medicare for all, we need to bring that in to the existing social movements, not silo it to a handful of healthcare activists and dedicated folks, many of whom are also working in the healthcare field. In order to do that, we need to acknowledge, address, and correct the eugenic history and the healthcare disparity that still exists today, and realize that in order to have any kind of credibility within a broader social movement. And I am absolutely confident that Southern folks, Southern working people are doing that. it is happening, and it needs to continue. We need to put our heads together. We need to share information. We need to build new relationships. We need to understand why many folks, support just immediate Medicaid expansion. And most of that just comes from extreme pressure from the mainstream Democratic Party, as opposed to, informed knowledge about what is actually possible. That's the other piece of this pie, right? We know that improved and expanded Medicare for all will actually save money, save lives, and produce a much healthier population. So I think in some ways, like the Medical Committee for Human Rights built relationships with the people on the ground and were willing and prepared to take leadership from the people on the ground, I think a lot of us in the South understand that that's the only way change really occurs, is from the bottom up. And that, I think, is a lesson that we can share with the whole country and build those kind of relationships with respect, with acknowledgement of the institutional racism that exists within historically, presently, and how improved Medicare for all can be a part of that solution, not an end-all be-all, but a part of that solution.
Rita Valenti was a nurse for 40 years and is a longtime single-payer advocate with Healthcare Now. Music for Southern Discomfort was recorded by Blue Dot Sessions. I'm Jonathan Michaels.